All right. So, thanks for coming, firstly. My name is Alex Bell. I'm a physio and I'm also the founder of the Running Room. So, um, I wanted to do a bit of a chat tonight. I want to keep this pretty informal as well. I don't want people not to be able to ask questions. I don't want to stand up here and talk 45 minutes. So, if you do have any burning questions or anything, like, please shout them out or put your hand up, or you don't have to put your hand up, actually, just shout them out. And we can go over, those questions together. So I thought what would be useful is like do a bit of a chat around a practical approach to running related injuries. Why I think that's really important is because there's a lot of misinformation out there about what actually matters when, you get injured or when you're training for something. I think you'll find out tonight, if maybe we'll just go a show of hands, like who's been injured here as a runner? Everyone, right? And so they're super common running related injuries. And really, the best way to prevent them is to not run. And obviously, we're not going to do that. And so there's some really nice little practical ways that we can build resilience in your tissue, things that we can kind of look out for, things that we should include into our training program that can often keep you, hopefully, injury-free, or at least reduce that injury risk. Before I start, I just wanted to say that it's such an incredible community that you have at Her Trails. I was speaking to you just before that, I do treat a lot of ladies online, and I know Sammy really, really well. And we're at Bondi and Manly last year doing the physio and saw a lot of you ladies there as well. And it's just like a really special community to see. Everyone I've met within the community is just so lovely. And so I think, what's being created here is something really special. So you should be really proud of the fact that you're involved and a big part of that. So it's awesome. Thank you. All right. So these are my objectives. These slides are a little wordy. So we're not going to go into too much of a deep dive into all of them, but we'll certainly cover some of it. I want to go over the fact that there's more to running related injuries than biomechanics. Often we think, is it the way I run? Maybe I'm overstriding, maybe I'm, pronating is something we hear sometimes. Then, you might hear like, have I got the right shoes? All of those things do matter, but we need to take an individualized approach. There's much more to running related injuries than purely biomechanics. I'm going to go over injury versus niggle. It's an important thing that we do here. We'd much rather treat someone when they have a niggle than an injury. You might feel something, and also go over like what's acceptable, because if we told you to only run when you had no pain, you'd probably never run at all. And so it's really important to know, okay, what pain is safe to run through and what pain is maybe not so safe. I want to go over load versus low capacity, and I'll explain what that means. The 10% rule is something that we still hear in the clinic. Should I follow the 10% rule to increase my training load? I'll show that maybe you shouldn't and why we shouldn't do that. And maybe a better way is to look at this acute versus chronic workload ratio and maybe have a look at just a bit of an idea in our mind of what that might mean and how we can increase our chronic load, which is a good thing. Sleep is the most important thing we can do to recover. There's a whole multitude of things out there that you'll see now: saunas, ice baths, meditation. All of that stuff is really, really good. And we promote that here as well. But if we're not getting enough sleep, then simply we just cannot recover. I'm going to go over 3 common running-related injuries. I haven't touched on anything. I thought we'd do another talk at another time, touching on like bone stress injuries and particularly RED-S, which is such a big thing in the whole running community, but particularly in the female running community. So I thought it's another talk entirely. I thought it wouldn't really do it justice by touching on it for 5 minutes. So I think we'll do another talk on that. But I wanted to cover these 3 common running-related injuries because they are super common. And then finally, strength training. I know all of you do strength training as part of the Her Trails program, which is awesome. And I'm a big proponent for that. It's something that runners have neglected for a long, long time. And probably just showing you why it's such a powerful tool. And maybe we don't have to overcomplicate things. We can just do a couple of things really, really well and maybe demystify some of the myths that might be there with strength training. So who am I? I'm a physio. I own and founded the Running Room. We have 2 locations here in Sydney. I've got 2 clinics in London as well. And I also am a big mental health advocate. So my good friend Ollie Woolrich and I created an initiative called More Than a Run. We did that this in its 4th year now. I lost my best mate to suicide, and ever since that day, I was kind of looking for a reason to create something that could bring community together. And what better community than the running community? We know people run for more than just physical health. And so I created something called More Than a Run with my good mate Ollie. And to date, I'm really proud to say that we've raised over $1.9 million for charity in 3 years. So another I really feel quite grateful that I can bring running. Really, it's a big part of my life. It's what I do in business. It's what I do, from a philanthropic standpoint. And yeah, I really run because of the mental health benefits that it gives me. All right, let's start with the why. I always think about this. So why do we assess and treat runners? Because they get injured a lot. But I think what I'd love to start shifting the focus, and it is happening, I think, within the running community, is what can we do as preventative measure to look at increasing performance and trying to stay injury-free? I think that this is a really big one. I just touched on it, but because running plays a huge role in people's mental health, it plays a huge role in our physical health, but also it plays a massive role in our identity and our social connection. And so if someone can't run, it's a big deal. And we see that in the clinic here all the time. It's not just a running-related injury. It actually really impacts someone's life. So if you're seeing a physio and they tell you not to run, it's probably not the best approach. And that's always, we want to try and keep our runners running. And that's really our ethos here is, can we modify things to keep you in the game? And because we know how important running is to people's lives. All right, some stats. So I said this before, but it really is true. The only way to prevent running-related injuries is to actually not run, and we're just not going to do that. So anywhere in the literature, they're basically very, very common. Between 90 and 80% or 79% is the incidence of running-related injuries. Where do runners get injured? The knee, probably not unsurprising. If I probably said again, like who's had knee pain whilst they've run, we could probably say that only 2 in this audience. Okay, I was going to say, but I was like, oof, maybe not. But that's typical. We know that running puts a lot of load in the knees, and that's where people typically, will experience injury. But anywhere lower leg, foot and ankle, hip and pelvis, and then thigh. One thing just to note is often you probably have heard like, running's bad for your knees, and it's actually not. So they've done some really nice studies and longitudinal studies where they look at knee osteoarthritis and the incidence of knee OA in runners versus non-runners. And they actually see that people who run have a lower incidence of knee osteoarthritis, which is really good. We know it's protective against cartilage to give it some load. What we see is people who run too much, like at that elite level, who have run for many, many years with really high training loads, they might have some high incidence, but the recreational runner actually has a lower incidence of OA. So next time someone says, yeah, it's bad for your knees, though, you can tell them that it's actually not. It's good for your knees. Masters runners, I think this is an important one because as we age and over the age of 40, we start getting different types of injuries. We start getting more tendon injuries and more calf injuries. As we get older, our calf takes the biggest hit in terms of the cross-sectional area and the strength that we lose. And so that often leads to more calf injuries and more tendon injuries. So glute tendons, Achilles, things like that. I'll skip through this, but novice runners get injured more. This is the biggest one. Previous running-related injury in the past 12 months is the biggest contributor, and certainly previous injury is the biggest contributor to getting another injury. So if you've been injured in that area, it's going to be the biggest risk factor for getting another injury. And sudden changes in load play a key role as well. So, spikes in training load play a massive role in injuries. And I think it's really important to know, we'll go into it in a little bit in a couple of slides, that load isn't just running. It's not just like, oh, well, I've done 60 kilometers this week. It's what you do outside of work, outside of running. Like, do you have a stressful job? How much sleep do you get? Do you do yoga as well? Do you walk the dog? All of those things play into our overall load. So running might not be the thing that kind of is the whole issue. It might be something else that we've kind of done that can impact our bodies as well. Okay, running biomechanics. I think this is a really important one. So the runner's ecosystem is something that we talk a lot about here. We need to hear your story before we can say like, oh yeah, like we can't just put a blanket rule and say, oh yeah, well, you overstride, so you're going to get knee pain. It doesn't work like that. We need to know exactly what's going on from your ecosystem. So exactly what I just said. Sleep, stress is a massive one in people's lives that can play a massive role in pain sensitization and developing injuries as well. Niggle versus injury, something that we talk about a lot here. So when we talk about a niggle, that might be something that, comes on a run, but warms up. So you might feel, let's take your Achilles tendon as an example. You might feel it on the first few steps of my run, maybe for the first kilometer. It's like a 2-3 out of 10. Generally, if we had a traffic light system, that's pretty safe to run through. So if we said green light was like, keep going. 0 to 3 is basically that green light for us. We can keep running. Once we start getting like amber light, okay, we should watch this. It's probably when it gets from like a 4 and starts creeping up 4, 5, 6. We should watch this. We can probably keep running, but we probably need to monitor, is that getting better over the days or is it getting worse? So, might get through that run, but then 2 days later, it's actually started at 3, but now it started at 5, and now that 5's a 6 pretty quickly, and it's not warming up, it's getting worse. And then it moves into that 7, 8, 9. That's like a red light. You need to pull back that run. It's probably not doing you any good at that point. And the reason why I say that is because we don't want it to turn into an injury. And that's typically what can happen if you continue. Like often we get these warning signs. We're like, yeah, how long have you had this injury? Oh, about 3 months. Often we get those warning signs. We're runners. Like we all do that, and we're all probably guilty of that. So what I would urge you to do is like, it's very rarely, once we pick something up as a niggle, it's very rare that we say, stop running. Often it's like making some modifications. I'm going to show you what injuries, what we can kind of do to keep you in the game. And that might be reducing speed work, or it might be reducing uphill running or downhill running. It might be putting something in your shoe, like a heel lift to deload, some of the load going through your Achilles. But very rarely we here at the running room are saying, hey, stop running. We know it just doesn't work. And in fact, we want to build, running load is actually really protective against injury if we kind of get it right and follow those guidelines. All right, load versus tissue capacity. So every tissue in the body has a tolerance to withstand load. Muscle, tendon, bone, ligament, all of it has an ability to withstand load. Then when we talk about load, we're talking about your training. Running, not just running, strength training, Pilates, yoga, like I said before, sleep, stress, all of that stuff, past injury history, all of that stuff plays a role in our ability or our load that our body's exposed to. So if we think of this continuum where we have load here and tissue capacity, if we exceed one really quickly, so we ramp up our training load really quickly and it exceeds our body's ability to withstand that load, hey presto, we get pain or injury. So what we're trying to do is we're trying to play this delicate dance where we actually want to load our tissues, because what that does, it's good for them. It actually increases our tissue capacity. But we want to try and sneak them up in unison, not go too far, or we get pain and injury. It's really important to know, because what happens when you go to someone and they say, hey, you just got to rest, take a few weeks off. Usually you feel great because you're not running. And so what happens here though, if you've got load and tissue capacity again, you totally rest. Load comes down, but tissue capacity doesn't stay here. What it does is it creeps down as well. And then we go, okay, cool, I'm going to go back to running. Well, we're doing 40 Ks a week, so we increase our load again, but our tissue capacity is not there. And hey, presto, we've got pain again. And so we get stuck in this loop where it's this perpetual cycle of rest more, tissue capacity lower, try and run again, it's still painful, more rest, tissue capacity. What we want to do is we want to slowly increase these. We can increase your body's ability to withstand load by not just running. That's where strength training can be such a powerful tool to give our body that kind of resilience, and our tissues can make them more resilient as well. It's such an important concept that it doesn't need to be overcomplicated. Sneak both of them up in unison without spiking your training load, and typically we can keep people in the game. We went through this. All right, 10% rule. Who's heard about the 10% rule? Increase your training load by 10%, probably won't get injured. That's the smartest way to do it. And it kind of works sometimes, but it doesn't really work a lot of the time. And the reason is like, what about intensity, frequency, terrain type of running? So if you said, okay, I'm going to do 40 Ks of running, but they're all going to be hill sprints, that's very different to saying I'm going to do 40 kilometers of base miles. Totally different beast, totally different type of training. Then we said, okay, well, what if you're completing 10 kilometers a week and you're under the 10% rule? That's not a big, you can probably tolerate a higher spike in load there. But once you get up to high loads, let's say you're doing 100 kilometers and you say, all right, 10% rule, adding 10 kilometers onto a 100K week is a fair bit. And so we need to have a better system in, okay, what can we utilize that's going to allow us to increase training load without getting injured? And I mean, luckily for you, ladies, you have some great programming from Sammy, so it's not really an issue. Hello, come on in. So this is something that we use a lot. Now, probably just to realize, I don't expect everyone to be like, oh yeah, cool, like looking at it in as much detail as we do here, but this is what we're looking at on the back end. When we're looking at some of your data, we pull your data a lot of the time from your Garmin, and we start looking at these things versus acute versus chronic load. So very simply, I want you to think about these things. Acute load is what you've done over a short period of time, say within a week. Chronic load is what you've done over a longer period of time. So if you think about, I often explain it like this. Think about a beer drinking analogy, okay, or a wine drinking analogy. Let's say you've drank wine every day for 12 months. You have 3 glasses of wine. If you have a glass of wine or 2 glasses of wine that following day, after doing it for a year, you're probably like, I'm not really going to notice that. If you hadn't had a drink for 12 months and then you had 3 or 4 wines, you might feel it the next day. And it's the same thing with this. If you haven't run for a long period of time and then you increase your acute load, that load you do over a short period of time, it's probably more chance you're going to get injured or going to have some sort of pain. So what we want to do is, chronic load is a really good thing. It's your fitness. It's being able to do consistent training for a long period of time so we can build this system of, your tendons, ligaments, bones, all of that to be super resilient and withstand the loads that running puts on your body. So that's what we kind of look at in the background. That's why we'll ask questions like, what's the last 3 months look like? Have you had any injuries? Did you have time off running? Like what sport did you play as a kid can be a really big one in developing bone health. So we often go back a long way to see, okay, how set up for you is your body to be able to withstand these loads? We touched on this before very briefly, but it is the biggest thing that you can do for recovery is sleep. And I often stand up here as someone who doesn't have kids as well. And sometimes, I'll say to my patients, like, just get sleep, and then I'll often say like, oh yeah, cool. Have you got any kids? Oh yeah, I got 2 kids. How old are they? Oh, 6 months and 3. I'm like, it's very easy for me to say like, oh, just get 8 hours of unbroken sleep. You recover fine. I absolutely understand the challenge. But it's probably just knowing some of these statistics that athletes who sleep less than 8 hours are at a 1.57 times increased risk of injury. And people who sleep less than 7 hours per day over the past 2 weeks, that was associated with a 51% increase in injury as well. And so it is just such a good way to recover. Yeah. It's a good question. Naps are okay. What we don't want to do is, and the people on YouTube for that was like, if you don't get 8 hours sleep, what can you do? Will naps make any difference? Probably the biggest thing I would say there, and it's hard, is you can't bank sleep. So you can't kind of go, sweet, well, during the week, maybe I'm like 6 hours, but on that weekend, I'm going to get 10 hours and that's going to like save me. It doesn't work like that. Naps can be good, and I definitely recommend that. Like if you can't like sleep through the night. But it's probably also just realizing like if your sleep has been affected. So it might be like 2 weeks where, you're not getting much sleep at all, like knowing that, hey, that might affect my ability to train and I might have to pull things back a little bit. Or if I have a niggle, maybe that's a contributor and maybe, I need to pull back my running or, just be mindful that, your sleep might be playing a role there. But I say it like it's so hard. It is so hard. Yeah. And stress is another one. Stress is a very similar one, in terms of not just like the stress in terms of training, but psychological stress can play a huge role, even on our hormones, but also in pain perception. It's a massive one. Takeaways: prioritize sleep and recovery. Adding any of the other 1%ers, ice bath, sauna, meditation, all of that stuff, great. But it never replaces sleep. Is the big rock. Yeah. Decreasing it. Yeah. And so sometimes it's about like, what else? It's probably been, thinking about what type of run. And I get it too. Like sometimes you just need to go out there and like blow off some steam. But maybe trying to do that where you're not doing that. Like it can't be your outlet every time to run hard and fast to like maybe a base mile run where you're still out there is enough to kind of clear the mind as well. And that would be better than, piling those hard runs on top of each other. Okay, running biomechanics. The takeaway here, and I'm mindful of time. Maybe Emma, you can keep me on time too if I start going over. Running biomechanics. The takeaway I want people to get from this is that there's no perfect way to run. There really isn't. And you'll see some high-level runners do some things that typically would be like, hey, that's not a great way to run, but they're phenomenal and they don't get injured. And so we really need to take an individualized approach to running mechanics. There's a couple of things that we'll often pick out that can make a big difference. And certainly if there's injuries, often what we can do is use a couple of things that can be a really efficient way to deload certain tissues. Cadence is one of them. And then trying to kind of goes hand in hand, but trying to reduce like someone's overstride. And when we're talking about overstride, we're really talking about the distance between where you land and your center of mass. There's no great evidence on what that distance should be. Like, should it be, half a meter, or should it be less than that? Because everyone has different limb length. It is really dependent on how long your legs are and are you running uphill, downhill, things like that. The best evidence we have is people landing with a vertical shin at impact. So overstriding like this, really straight kind of knee, you're kind of landing with the brakes on it, puts a lot more load in your shin, a lot more load in your knee. So trying to get underneath yourself. And the easiest way to do that if someone has a low cadence, does everyone know what cadence is here? Cool. And so when we're talking about cadence, we're trying to increase someone's step rate. So it's how many steps you're taking per minute. If you were to Google that, often you'll see like 180 is the best cadence, right? We know it's just not true. And so again, we need to individualize that. So that doesn't take into account how tall you are, how heavy you are, how fast you're running. Are you running uphill, downhill? Is it trail? Is it technical trail? Like all of those things play a role into how many steps you should take. And so the best evidence is taking your individualized step rate, your cadence, and increasing that potentially by 5 to 10%, only if it's low. And if it's low, usually it's like anything under 165 is typically considered in the literature to be low. And that's probably the biggest one with biomechanics that we'll play with here to make an impact. I've got a slide coming up that shows how much it can deload certain areas. So that's a really big one. Don't worry about this too much. Overstriding is what we just discussed. Like that's probably one of the big ones. The other one can be like contralateral pelvic drop. So that's, when you hit the ground and you're getting this kind of hip drop, your knee adduction, when that knee's dropping in, the same thing. Again, it doesn't always matter. Patellofemoral pain or runner's knee is a really big one for that. So often we say it's a correlation, not a causation. And what I mean by that is we can see runners who don't have knee pain, who hit the ground, do this, and their knee falls in. So it doesn't mean it's going to cause you knee pain, but often what we say is that when we see in the literature, when we see people with runner's knee, usually we see this. Usually we see that hip drop and that knee falling in. So it's probably a good idea to try and, mitigate that a little bit. And some gait retraining stuff can help with that. Cadence can be a big one. And then we often apply strength as well to increase the capacity. I spoke about this, but this is what I wanted to show you, that just some of these numbers, and this is why when we use that 5 to 10% increase in cadence, it can have a positive impact on so many things. Hip adduction, so that's that hip or that knee falling in, it's coming from the hip, can reduce by 3 to 4 degrees. It reduces that demand in your glutes by 9 to 11%, lowers your Achilles tendon force, reduces loads at the patellofemoral joint, that's your kneecap. So this is probably the biggest one that we'll use it on. If someone has runner's knee, which is the most common running-related injury, and they've got a low step rate, it's such a great tool to try and mitigate some of those loads. And it can be a really nice way to increase that. People's knee pain goes away, hey presto, like let's keep going. So it can be a really powerful tool in that sense. We've touched on that, there's no magic number. So it shouldn't be 180, yours should be different to mine, it has to be individualized.
Do you only work that out by seeing physio, or do you kind of do an average?
You definitely can. So what I would usually suggest when people are trying to change their cadence is your cadence will naturally change as you run different speeds as well. So like if you're running 6-minute pace, your cadence shouldn't be the same as if you're running 4:30. So what I usually tell people to do is we're trying to change your kind of default. So I'll usually go like, okay, what's your base mile run? What pace do you do? That's a fairly flat, not uphill, nothing like that. You can get it off your Garmin. It's really easy. I can show you guys later. You can jump into your Garmin Connect and see what your cadence is on those runs. Then what I usually do is just increase that by 5 to 10%. The key takeaway here though is that when we're increasing someone's cadence, your speed has to stay the same. Because if I say to you, okay, it was 165, let's pump it up to 170, and then you're like, oh yeah, cool, I'll go for that run again, and it was your base mile run at 6-minute pace, but then you start running 170, you'll naturally want to run faster. So a treadmill can be a really easy way to change it because you set the speed, you can't outrun the treadmill or you hit the front of it. Or, you know, you're just speed checking. You're like, cool, 6-minute pace or whatever pace your base mile is, increase it by, I usually start with 5% and then see, okay, I'm just going to speed check and keep looking at my watch and like, cool, I'm holding myself back. And that's where the efficiency comes. Otherwise, if you're just running faster, it does nothing. You're just running faster. Cool. I'm not going to read this out, but I just want to show you, this is a systematic review, okay? So it's looking at what biomechanical risk factors contribute to running-related injuries. It's a 2009 study. Look at how many studies have been published. This is what they looked at. All of these things is what they looked at. You don't have to worry about what they mean. But what I want you to know is that these little asterisks essentially highlight that there's low evidence to suggest that this makes you can predict running-related injuries based off this stuff. So like all of these studies, we need to, when we apply this blanket rule, it doesn't work. We have to take that individualized approach to running injuries, or we can't just say, hey, this is why. It's just the evidence just isn't there. I want to talk about some 3 common running related injuries. This is the most common of them all, runner's knee. We had a show of hands. Everyone's had a bit of knee pain, probably at the front of the knee in the past. It basically makes up 50% of running related injuries. This is a big one. So if you've had past injury history of patellofemoral pain, you're literally 50 to 80% more likely to get it again. So it's such a big predictor in whether you'll get that injury again. Females, are more likely to experience runner's knee than males. And this is a big one that recent increase in training loads can contribute. So I put this in here as well. So downhill running and then return to run. 2 big ones. What your quads do when you run. Often when we think about running, it's like my glutes don't fire, or, you know, I've got weak hamstrings. What we know that the muscles that contribute to propulsive force to drive you forward, the biggest contributor is your calf. Your calf does most of the work there in driving you forward. What your glutes and quads do is they're shock attenuators. They help you to absorb shock. And so your quads play a big role in this. Think about the last time you've done a long downhill run, maybe on trail. Usually your quads are like, oh yeah, I'm feeling this, you know, because they have to work so hard in that braking force, and that can really increase the loads going through this joint as well. So that might be something when we think about, okay, how can we keep people running? This is probably one of the ones that we usually, that's a lever that we'll pull. It's like, cool, we're going to reduce downhill running. And that can decrease the load in your knee. What does it feel like? We know it's pain in around the front of our knee. It's pain with sitting, squatting, running, downhill running. Often people will say that. I sit for long periods of time and stand up. Geez, my knees are sore. It's a good sign that your patellofemoral joint's a little bit irritated. Squatting, things like that can often irritate your knee as well. This is when we think about the niggle versus injury concept. We know in the literature that people who get best results when they have runner's knee is if they get treatment early. So rather than let it going on for months and months, because often you can with patellofemoral pain, you can kind of keep running through it. If you get an early diagnosis and treatment, people have better outcomes, and we see that in the literature. How do we fix it? Well, we strengthen up your hip first, and in conjunction with your knee. I'll put this in here, taping and orthotics. Taping can actually be really effective with knee, patellofemoral joint pain, but only if it works. And what I mean by that is, like, we just test it. We test it in the clinic. We tape someone's knee. We get them to squat again. Does it feel better? Yep. Okay, it's probably a good indication that it's going to work. Tape it, get you to squat. Feels no different? Probably don't tape it. Not going to do anything. And the same with orthotics. We will use them, and there's good evidence to show that they help if they're combined with strength and physio in the short term at 6 to 12 weeks, but only if they're going to work. And the best way to do that is tape someone's foot or whack you, like put an orthotic under their shoe, get them to squat again. Does it feel better? Yes, it's usually a good thing that we can, usually a good thing that we can roll out, but only in the short term. It's never like a life sentence. You don't have to have orthotics forever. It's whilst the evidence there is for that 6 to 12 weeks to keep people running, and then, you know, with the idea of pulling them out one day. Cadence we spoke about, uphill rather than downhill, reduced load, and then footwear. This is a good one as well. So often when we talk about the heel to toe drop, does everyone know what I'm talking about when we speak about that? If we lower the drop of the shoe, so we go into something that's more minimalistic, it can often deload the loads that go into your knee as well. We just need to be really aware of what we're doing there, because we're just shifting load around. We're pushing load from the knee, we're putting it back into the calf and the Achilles. And so if the calf and Achilles doesn't have good capacity to withstand load, we might fix someone's knee pain, but we might give them Achilles tendinopathy. So we always need to know, okay, what kind of capacity do people have to withstand some of those changes? And it's not a change that I make all the time, but we might reduce it slightly, like go from a 10 mil drop to maybe a 6, something like that. I put this slide in here, and this is Rich Willey, who's a great running researcher out of the University of Montana. And I thought this is a really interesting one because when we look at the difference between walking and running, you can see that the loads, patellofemoral is your kneecap, the loads that go through the knee when we transition from walking to running are phenomenal. And it's probably why we get it a lot when we start running again or we haven't run for a while, is that, they're 4 to 6 times greater than the loads that we experience when we walk. Hip and Achilles are about 2 times that load. Sounds like a bit, but it's not really. And that's why when we have hip and Achilles issues, it can be a really nice way to cross train is just to walk, because the loads aren't too different as part of your rehab. Whereas with patellofemoral, we need to make sure that we're getting these knees really resilient to be able to withstand that increasing load, because it's so dramatic. IT band pain, next one. Most common cause of lateral knee pain. Has anyone had IT band issues here? Anyone who's had IT band issues know that it's very different to patellofemoral pain. It feels like when it gets bad, someone sticking a screwdriver in the side of your knee when you run. It's horrible. It's really sharp and it's really nasty. What we thought was happening probably isn't happening. So a few years ago, we used to say, I've got IT band friction syndrome. We actually now know that nothing's been frictioned. And it probably highlights the need to not like foam roll and stretch and all that stuff, because it's not a friction type injury. What it is your IT band is really tethered quite securely down to the outside of your knee. And there's some adipose, like some fatty tissue that sits underneath the IT band. That fatty tissue has a lot of nerve structures in it. It's highly innervated. When you go through, it's 25 to 35 degrees of knee flexion, which is what happens when you run. Particularly when you run downhill. And when you start doing more speed work, you get more hip extension. And so you get more of this load in the outside of the knee. That fatty tissue can become inflamed and it gets super painful. This isn't one of those injuries where I'll say to someone, just keep running through it, you'll be fine. It's often you need to have a period where you really pull back your running. And often what that looks like is reduced downhill. Trail running can be another one, because narrow step width can often be can put more load in the IT band as well. And so if you're running trail where, it can be quite narrow, you often have to, run more narrow, and that puts more load in your knee. The things that IT bands love is uphill. And so it's hard to say to someone, because what goes up must come down, right? It's like, how do you do that? The treadmill can be your best mate when you've got IT band issues. Hiking uphill at a really big incline can still keep some of that fitness going, without getting too much load going through the IT band. And then we often progress to incline running, kind of 3 to 5 degrees, and get people going like that. And then cycling can be a nice cross training as well. You just put the seat a little bit lower, so you're not going through this compressive range, because that 25 to 35 degrees of knee bend that irritates that knee with IT band issues. The biggest thing I want to show you here is that foam rolling. We see that stiffness in your IT band is no different between people who get IT band injuries or that compression and who don't. And so foam rolling, if it's a compression injury, we don't want to roll the outside of the knee. It's okay to roll up here. You're releasing your quad more than your IT band. Your IT band is such a stiff structure that it requires so much force to deform. So you can roll up all of this, but if you're rolling your IT band, it's not going to make it looser. And if you make it looser, it's not going to do anything anyway. Your IT band is like a tendon. Have you been rolling IT bands? It's still good to do. It's definitely, it won't do you any harm as long as you're not rolling here. Like, don't roll in around where it's sore in the knee. If you're rolling up here, that's fine. It's absolutely fine to do. It really is. It won't fix your IT band though, but it certainly can help with your quad and things like that. I'll show you some other ways that might be a little bit better. Okay, we've spoken about this. Reduced load, no downhill, no speed work. Uphill running is great. Cycling's good, and walking incline on the treadmill, 10%. Still get you a really good workout, but won't irritate your knee. We want to restore capacity by strengthening up your hip, and then we want to do plyometrics. So what we're trying to do is then introduce some more of this compressive load. So Bulgarian split leg squats after your knee has settled down can be a really nice way to load up your RT band. That's when you're putting your foot up on a bench, and everyone's probably seen them, and you do single leg squats down in that position. It's actually the trailing leg, so the leg that's up on the bench, that's going to be loaded more into that compressive position. So that's what we're nearly trying to sit back into that position and get that hip opening up and kind of load that RT band through that compressive zone. But we only do that when your knee starts to settle. All right, final one, Achilles tendinopathy. It affects, should be a dash there? Oh, no, there is. Yep, 2 to 18% of runners annually. It's the most common running injury in masters runners. What contributes to this is speed of running, and that leads to increased loads in the tendon. And then uphill running as well can be a big contributor. Probably why I'm showing you these 3 injuries is because we can start to see, okay, like there's very different modifications to people's running depending on what injury you've got. So like if we run, what loads your Achilles tendon the most is when you hit the ground and you come into mid stance and you're in this position here. When you're at mid stance, that's when peak loading of the Achilles tendon happens. It's actually just after that. What's happening to my ankle? Well, I'm going into what's called dorsiflexion. So I'm going into more of this stretch through the calf and Achilles complex. So you can appreciate if we run uphill, what do we do there? We actually just put more load into our Achilles. So if someone comes to us with Achilles issues, it's going to be very different than if they come to us with patellofemoral pain in terms of what running we might tell them. Like we'll tell patellofemoral people to run uphill, whereas Achilles, we're like, don't do that. It'll load you more. We actually see that faster running with knee pain, patellofemoral pain, can actually be not too bad on knees, but it's not good for RT bands and it's not good for Achilles. So we need to have this nuance between how we keep people in the game, how we keep them running. It's really important to know what loads are going through different tissues. Males are more common, lower calf strength, loss of tendon stiffness. This is an interesting one. If people have been on broad spectrum antibiotics, they're more likely to get tendon issues. Previous Achilles pain, again, changing training loads. This is where changing in footwear, that low drop shoe can really impact people's Achilles loads. We see it commonly when someone's gone to more of an aggressive shoe. It can really impact things as well. And then we touch on this, more heels and more speed. I went through this as well, classic signs and things to watch out for. I put this in here because it's something we see commonly in the clinic. Achilles tendon, usually that stiffness in the morning. Has anyone had tendinopathy in their Achilles? Okay, cool. Usually you get stiffness in the morning, things like that. Usually what we need for it to be tendinopathy is we need to have like a dose-dependent or a velocity-dependent increase in pain. What I mean by that is this. If I do a calf raise like this, it usually doesn't hurt. If I hop, I'm asking my tendon to store and release energy really quickly. It's like, oh yeah, that hurts. Tendons typically warm up. So you run, I feel it, and then it's like, kind of goes away after that kilometer, and then it's worse after activity. You stop, sit down for a bit, stand back up, it's stiff again, then it warms up. The reason I say this is because often what we see is that people are like, yeah, I've been doing those calf raises. I saw the physio and he gave me calf raises and just not getting better. It's because sometimes we get something which is called the peritendon involvement, and that's the outer layer of the tendon. What we see there is like things don't warm up. When you start running, you feel it. It gets worse and worse and worse and worse. That's not a tendinopathy. That's the outer layer of the tendon being really inflamed. And if you just keep doing calf raises, you're sliding and gliding that tendon through this outer layer, and it just gets more and more irritated. So that's one where we'll often use like Voltaren gel and Glad Wrap and slowly absorb that into the tendon. And it's one where we'll just say, hey, we need to pull back from calf raises. They often go well, kind of like they're called quasi-isometrics, where we kind of get people to walk upstairs, just holding their heel off the ground. And that can be a good one for them. Don't worry about these too much, but it's just some other differential diagnoses that we're definitely aware of. Medial pain could be plantaris. Lateral could be the nerves irritated. We do some testing for that. And bursa could be another one that we treat very differently to Achilles tendinopathy. What to do? They need load. So reduce load, reduce speed, reduce uphill. This is an interesting one. So a heel lift. If you, no one's had it here, so it's okay. But if you do get it, put a little heel lift. A 4 mil heel lift can be a really effective way of just increasing the drop on the shoe. So you're just turning that 10 into a 14 mil. And that deload, what it does is at mid stance, instead of being here, the heel comes up a little bit. So we reduce some of that load that goes through the Achilles tendon. So it can be a nice way to keep people in the game as well. The other one is hockers. So a rocker bottom shoe can be a really nice way to, there's good evidence to show that that'll decrease the loads at the Achilles tendon as well. All right, final thing. Role of strength training. This has been the biggest thing that I've seen probably shifting in the last few years, that runners previously, like I've been a physio for 10 years. When I first started training runners, it was like, I don't want to do strength training though. And it's like, it'll make me bigger or more bulky, or I'll put on size, or I've just got to run more. It's really hard to get runners doing strength. I feel like that's changing now, and people are starting to adapt and be like, okay, cool. Like, I often say that no one really cares about injuries until you're injured. But if you say to a runner like, hey, this is going to increase your performance, it's going to make you run better, people are like, all right, I'm in. Like, I can get around that. I can get around that. And so we see that this is coming up in the literature more and more and more. So it increases running economy. It's been proven time and time again. There was a nice systematic review that looked at 24 studies and increased your running economy by 2 to 8%. So if people are running and putting a Vaporfly on or something like that, trying to search for that carbon plated shoe and trying to get 4%, it's like, hey, we can give you 8%. Just do some strength. It can be really effective. Time trial performance goes up as well. And then this is a big one. So we see that 18 studies found that there was no change in body mass for those individuals who did strength training and still ran. It doesn't change. And body composition was unaffected in runners who complete resistance training. So we just see that if people are running, it's very hard to put on size, like muscular size, if you're going to run. And the amount of strength training we're getting people to do isn't at high enough volumes for them really to get bulky and put on size. So it's a really effective way. And then, haven't put it in here, but really good for bone health, really good for tendons. It really is such a powerful tool and should be implemented, I think, with every runner. And this reduction in injury risk has been seen as well. Finally, what do we need to strengthen? I usually get people to guess this first. I kind of gave you the answer before. But this is the big one. When we look at these body weights of force going through the calf, this is soleus and your gastroc. 6.5 to 8 times your body weight going through that calf muscle when you run. If we compare that somewhere to, the glutes, where we're looking at 2.5 to 3.5. So when we're thinking about like, oh yeah, my glutes don't fire, it's probably not really the biggest thing we need to address. Like, we need to get people's calves strong. And it's probably the one thing that runners neglect is like, I'll do some strength. I'll do squats and I'll do some, side planks, and I'll do something for my glutes, and I'll do bridges and all this stuff. But like, a lot of them like, do you do calf raises? No, I don't. If you were to take one thing away from this talk, it would be start calf raises into your routine. And they're so easy to do. And I'll show you how we're going to do them in a minute. This is what we call our running room fundamentals. A big problem that we see in when runners implement strength training into their routine is they think, hey, I'm a distance runner. So if I'm a distance runner, then what I should do is I should do like high reps and low load, because I'm trying to train for endurance. That's what I do. We see that it's not the case at all. So we don't want to be doing like 20 repetitions of body weight exercises. What we actually want to do is we want to give people some super maximal load, some dumbbells, kettlebells, something like that. It doesn't have to be crazy heavy, but the stimulus needs to be higher than body weight. And the reason is because of exactly what we just showed you before. When we look at these loads, I don't expect anyone to hold 8 times their body weight and start doing calf raises. But you can see that those loads are so high that we need to try and expose the tissue to some higher loads. So the key is we need to do heavy, slow resistance. Reps should be lower with higher weight. We should be doing compound movements. So that's like, we don't need to overcomplicate it. Do a deadlift or a squat. Do a squat. We pick a single leg exercise as well, because when you run, you're on one leg or none. And so a single leg squat works really well. Single leg bridge, those kind of things can be really, really nice. Calf strength is huge. We have to add this into our repertoire, and then throw in some core. And then we'll start looking, okay, exercise specific to your running related injury. What have you had in the past? Where's your deficit? I've had knee pain. Cool. Let's strengthen up your knees a bit more. Or I've had hip pain. Cool. Let's target your hip a little bit more. So we kind of throw that into the mix as well. And then some plyometrics are really important also. Takeaways from tonight, and then I'm going to throw it across the Q&A. Running related injuries are common, super common. People get injured a lot when they run. It's inevitable. It's about how do we deal with them and how do we keep people running when you deal with a niggle before it turns into an injury. We need to address the entire ecosystem. Sleep more is a big takeaway. See someone when you have a niggle before it turns into an injury. Strength training is a key component to a runner's training. And if you're injured, you need to see someone who's going to tell you that you can still run. It doesn't work when we tell runners just to simply rest. It just doesn't work. We get stuck in this loop where we get injured, rest more, injured, rest more. We need to keep people in the game with some of these modifications that work really nicely. And finally, no two injuries are the same. We need to individualize people's treatment. We can't give a cookie cutter approach to everyone and say this is how everyone should run, or every Achilles injury is the same. They're just not. They're just very, very individualized. And that's why we need to take that approach. You can reach me here, email me anytime. Check out our Instagram at The Running Room. We post a fair bit over there. And if anyone is suffering from any running related injury, like I said to you ladies before, I think before we jumped on, I've seen a lot of Her Trail runners from all over the country. And yeah, it's been a really lovely experience. I do online physio, and I think often that's something that when we talk about that, people are like, yeah, how does that work? And I was saying to a few of you before, like, it works really well. We pull your data off your Garmin, we create strength programs, we hear your story, because that's actually what matters. And then we get you do some things in the, like, online, get you to hop, show me your squat, show me your single leg squat, all of that stuff that we can still see visually. The only thing we can't do is hands-on treatment. And what I'll do with that is often just refer people to someone who can, and it depends on what state you're in. And hopefully you've taken away that sometimes that isn't the be all and end all in terms of like IT band and foam rolling. Thank you so much. Does anyone have any questions? Yeah. So I'll just repeat the question so they hear it online. So the question was, why wouldn't you roll your IT band when it's injured? The reason is because it's not a friction injury, and so it's nothing to do with your IT band necessarily being tight. And so what we're trying to do there is, like, we're not actually trying to loosen it. What we're trying to do is desensitize the tissue underneath your IT band. So your IT band comes down here. It starts at your ilium, which is your hip, and then it runs down into what's called your Gerdy's tubercle. It actually attaches below your knee into your tibia, into this bony part of your leg. Underneath your IT band, around what's called your femoral condyle, that bumpy bone on the outside of your knee, there's a fat pad that sits under there. It's a lot of adipose, like fatty tissue. Everyone's got it. And it's got a lot of nerve structures in it, heaps and heaps of neural structures. So what we do is, like, when it gets irritated, it's a compression injury. When you're coming through this first 25 to 35 degrees of range, you're compressing that IT band into the fatty pad. When it's inflamed and irritated, if you're rolling on that area, it's actually just irritating it more. And so I say this because, like, you can absolutely roll like to here. Roll that thigh. You can get a trigger ball into your glute. Like, your TFL is a muscle that inserts into that IT band. And then 75% of your glute max inserts into that band as well. Get a ball into it. If that's going to relieve your symptoms, absolutely. It's probably more so when people are foam rolling the outside of their knee and really going down, like, quite low. It actually doesn't do anything. It's actually worse for you to do that. But certainly up around the upper part of the thigh into the hip is a good thing, for sure. And it's just because we're not actually trying to loosen it. We're trying to desensitize it and let it calm down. So often what I'll do with that as well is, that's when I might use some, like, topical anti-inflammatory, like a Voltaren, and we'll get people to, like, put that on the side of the knee and then glad wrap it as well. And all that glad wrap does is just slow down the absorption, so it doesn't go straight into the tissue. It kind of gets absorbed more slowly. That can be effective. If it's not settling down, sometimes we'll opt for, like, a cortisone injection into that fatty pad. And then it's still not settling down. Like, they can become things where we might get, like, a surgical release of your IT band. It's not common. I don't want anyone here to start thinking they're going to need that. It's really not common. But yeah, that's why you don't foam roll that foam roll.
What's your take on, like, stretching and warming up?
Good. It's a great question. So stretching and warming up for injury prevention. If you're doing a warm up, it should be dynamic. So gone are the days where no static. Like, we actually see the injury risk is higher in people who do, like, okay, cool, yep, I'm going to do, yep, going for a run, I'm going to do this, yep, going to do this. We actually see that your injury risk goes up. What you should do is basically do something at a lower load that's going to replicate the demands of that. So if you're going for a jog, or then doing some A skips, some high knees, things like that, that's definitely worthwhile. And then post run, like, you can go hardest. Like, if you want to stretch and it makes you feel good, do it. I think it can be a really, like, I'm not anti-stretching either. Like I really not. I think that it can be a nice way to like down regulate things, calm things down. I'm probably not such a big proponent of people, and we hear it still commonly. It's like, oh, it's just because I don't stretch enough. But then when people aren't doing any strength training or anything like that, I'm like, the big rock is strength. You know, if you can get your tissue more resilient, don't worry about the stretching. But if you want to add that after your runs, it's still a good thing to do. The only caveat to that would be where I'll actually tell people not to stretch is if you've got like an insertional Achilles issue, so Achilles issue that's right down the bottom of your heel, or like an upper like hamstring, like a proximal hamstring tendinopathy. Because your hamstring tendon wraps around your sitting bone, it's called the ischial tuberosity. Anytime you get compressive load, so anytime you do this, anytime you're in hip flexion, anytime you're in downward dog, anytime you're anything like that where the tendon's wrapping around the bone, it adds compressive load. And so that can be a big one where we'll say, hey, stop doing, like stop stretching. And that can be a really powerful tool to like just change that. That's really get someone out of pain. And same with Achilles. People will stretch their Achilles. It's actually not a good thing to do it, particularly if it's down low, right on the heel bone. Yeah.
And would you recommend always warming up beforehand?
I would. Yeah, I would. Especially maybe if, yes, like if you had time, absolutely. I think certainly on your runs, like let's say you're going out for a base mile run and you're like, oh, I don't really have time. That run's not going to be as kind of, it's not going to be as important because it's a slow, cruisy run. If you're like, hey, we've got, a tempo session or hill sprints or anything like that, I'm like, you should warm up. You should definitely warm up. Probably the other thing on that is when we talk about strength training, you probably don't want to do it if you're going like if you know you've got a hard session that's like involving a lot of speed, things like that. I wouldn't be doing my strength training immediately before. You can do it after, but not before because you don't want to put too much fatigue in your system and then go ahead and do a really hard session. You probably want to do it the other way. Yeah, that's a good question there. Any other questions? Again, same thing. Like I think the massage gun can be a really powerful tool post training. It could even be like warm up. The other thing is like I would go more in like the meaty part of your muscles, right? So like I wouldn't be on the side of my knee, or I wouldn't be like right on the side of my hip in that bony prominence you graduate can. It doesn't do that much, but certainly if you're in through kind of your really the muscle bellies, I'm all for that. And foam rolling as well. Like I'm not anti foam rolling or trigger ball. I give that to a huge amount of my clients. It's probably more so just with the IT band. When someone has that irritation, I'm like, don't do that on your outside of your knee. But I love foam rolling. There's some good evidence to show that it has a really short-term effect on like muscle length and stuff like that as well if you foam roll. So yeah, I'll get people to on the like trigger ball through their glutes, TFL, rolling their quads, hamstrings, calves, or a gun. Same thing, really. Yeah, I'm all for that. Cool. Hey, thank you so much for giving up some of your time to come in here and listen to me speak. Hopefully everyone got something out of that. If there's any follow-up questions or anything, please absolutely reach out to me. And yeah, probably just want to say that again, like I said at the start of this talk, but I think what's being created here with Her Trails is pretty special. Yeah, like I said, and not just in one state, like I've treated women all over the country and everyone I've jumped on with has been so lovely and spoke so highly of the community. And so, yeah, probably just big ups to you all for, being part of something so special. So yeah, thank you so much. Thank you. Oh, good.